Welcome to BreakThrough. This course is designed to help individuals recover from inseparable mental and weight-related metabolic health conditions. Metabolic health includes factors such as obesity, cardiovascular disease, type 2 diabetes, PCOS, and more. Throughout the course, clinical research is integrated with resources from the BreakThrough program, as well as facilitator observations and experiences from a decade of working with individuals and groups, in person and virtual.
Welcome, I'm Dr. Heather Hamilton, the founder of Team BreakThrough and Director of Innovation, Research, and Content Development.
And I'm Dr. Jenday Stafford, the Director of Professional Education for Team BreakThrough. Both Heather and I will be with you through these sessions. Our invitation to providers and participants is simple. Take your seat at the table, wherever that table may be.
The course text and workbook, as well as provider resources, were entirely revised for the fifth time in 2025 and presented at the 2025 ACA conference in Orlando. BreakThrough is best described as a living course. A course that continues to be inspired, shaped, and updated by both provider and participant lived experiences, as well as the latest in clinical research. Humorously, the course began in 2014 with the simple outline you see here. An outline scribbled across 15 pieces of paper held together by Scotch tape and updated with margin notes as our team began facilitating weekly in-person groups in 2015. Over the next several years, the questions, insights, narratives, and shared experience of over 3,000 participants helped our team refine and personalize the course and publications.
In 2018, training for mental health providers was introduced in a 6-hour CE workshop at the American Counseling Association National Convention in Atlanta. Since then, continuing education approval for licensed providers in North America has been maintained by the National Board for Counselor Credentialing. With the onset of the pandemic, all BreakThrough courses transitioned to next-generation digital platforms to meet the needs of virtual and blended group environments. These upgrades make it possible for Team BreakThrough to seamlessly and continuously update course resources, as well as our bot Brian with the latest in emerging peer-reviewed research and supportive evidence-informed practices.
With unprecedented shortages in supportive integrative resources and funding, job burnout is at an all-time high across the healthcare professions. To that end, our focus has been to design and structure resources that help alleviate provider burnout by encouraging participants to become active stakeholders in their own recovery. There's no question that there's a critical need for comprehensive, inclusive, and accessible treatment programs that support recovery from inseparable mental and metabolic health conditions. In 2021, the CDC reported that 1 in 5 adults in the United States was suffering with a mental health disorder, and separately, 2 in 5 were suffering with obesity and related metabolic health conditions. The CDC and World Health Organization both estimate that the lifetime prevalence of suffering with a mental health illness is approximately 50%, and the projections for the development of metabolic health disorders are strikingly similar. By 2030, it's estimated that 50% of adults in the U.S. will meet the criteria for obesity.
In the U.S., cardiovascular disease, type 2 diabetes, and complications from obesity are attributed to 1,400 premature deaths every day. In many cases, these illnesses and deaths are preventable. For the past 4 decades or more, metabolic health recovery focused on weight loss behaviors without considering a comprehensive approach to overall patient wellness. Treatment has often exclusively relied on medication, diet, and exercise, but this approach has failed to stem the epidemic of obesity. With the exception of bariatric surgery, less than 20% of the population with the resources to engage in metabolic recovery have been successful at sustaining weight loss for more than 2 years. Sadly, for 80% of adults in the U.S., frustrating patterns of behavioral relapse and weight regain have been the norm, rather than the exception. Relapse prevention and sustainable recovery depends on awareness, decision-making, motivation, a positive mindset, resilience, and more. These are key cognitive and emotional constructs directly supported by mental health and emotional well-being.
Everything that's happening in our brain affects our body, and everything happening with our body affects our cognitive and emotional functioning. When we review research from the last decade, it's now evident at the most fundamental cellular level that the optimal approach to wellness rests on integrated care for mental, physical, and metabolic health conditions. Mental health disorders such as depression, anxiety, bipolar disorder, ADHD, and PTSD are all associated with high crossover rates for the development of metabolic health conditions. In some cases, such as ADHD, these associations are greater than 70%. These are a few of the core psychological theories and evidence-informed practices that serve as the foundation for this course. They're integrated in a progressive approach, blending knowledge and skills to help participants overcome challenges that often undermine the behavioral changes that support sustainable lifestyle recovery. Wherever possible, throughout the breakthrough. Course text, you'll find embedded hyperlinks that directly open publications and reference resources.
The BreakThrough 4R framework is designed to develop recognition and awareness, resistance, and progressively engage in the challenge of cognitive and emotional restructuring that leads to resilience and recovery. The goal is to help us develop a positive, empowering sense of self that celebrates our strengths, acknowledges preferences, with the awareness to recognize challenges, and implement skills for success.
Following along with the previous slides, this illustration shows how the evidence-based theories and approaches align to support our journey of recovery. As you can see from this slide, there are a lot of mental health conditions and factors that can contribute to emotional or impulsive eating behaviors and the onset of metabolic health conditions. Day to day, many participants share that they've stopped doing a lot of things because they no longer feel comfortable in public. Some share a great deal of sadness. Their partner may have withdrawn intimacy, maybe a distant memory, and shame may have crept into the relationship dynamic.
What makes this course unique is the broad range of topics we'll be covering as we blend information, skills, and opportunities for participant introspection and insight. It's important to note that throughout this course, we use the term metabolic health. Metabolic health is a broad yet inclusive term that includes conditions or illness such as type 2 diabetes, cardiovascular disease, excess weight, immune disorders, and other relevant health challenges. Wherever possible, metabolic health is used in place of obesity. We feel that this term accurately reflects health conditions and avoids unnecessary negative associations, stigma, or labeling.
We all need breaks, so from time to time, we include short videos or animation that encourages us to stop for a few moments, take a few deep breaths, and stretch.
Entire sessions are devoted to topics such as recovery from depression, anxiety, trauma disorders, as well as developing our understanding of the intricacies of brain and body health. That said, we know that our mental and metabolic challenges are deeply rooted within the social and environmental aspects of our lives. As the course unfolds, we explore aspects of health within the context of family of origin, social relationships, the workplace, and much more. This is the overview slide for Session 1. Here we present the topics discussed in this first session, and each of the session presentations are similar. Generally, this slide is a good opportunity for facilitators to share a short briefing on how sessions will unfold. For virtual groups, this is a good time to review any group rules, use of chat features, as well as the timeline for open discussion and reviewing inter-session homework.
This may seem like a lot of information all at once, but we can take this journey at the pace that is comfortable for you. When possible, we encourage participants to do one section at a time and take breaks to stretch, play with a pet, pursue a fun hobby, or take a short walk. We find that by introducing key psychological approaches up front, that it helps us understand the process of cognitive and emotional restructuring and psychological change. Most of us are apprehensive when we contemplate change, but change is happening around us all the time. Apprehension is a perfectly normal response. Remember that our focus is on progress, not perfection. While we encourage you to work ahead of each session, we also know that participants have busy lives. There will be sessions when pre-reading or homework isn't complete, and we simply encourage you to continue to attend and participate.
We know that everyone has a sense of their readiness or dreadiness for embarking on significant life changes. Because of unique challenges and circumstances, individual motivation can range from denial and apathy all the way to enthusiastic commitment. Early on, we find that when participants are exploring significant changes, it's not unusual to focus on tasks and underestimate the emotional challenges that will arise in the process of recovery. To keep frustration at bay, we'll frequently remind everyone that we want to focus on overall progress rather than perfection. The underlying spirit of collaboration in this course aligns with the premise that we have within ourselves the desire to reach our dreams and potential. Our role is to share the wisdom, skills, and resources that support this journey of healing and recovery. These are some of the reflective questions from the course workbook that help us identify concerns with health or body image and any strategies that may have been helpful in the past. Food and social interactions are among our earliest and most primitive needs. From birth through infancy, we learn to associate feelings of comfort, nurturing, and security with the provider of food, usually our mother. We explore attachment theory early in this course because among our first emotional experiences after we're born are the connections between food, comfort, and nurturing. The empathic capability of caregivers is crucial for the development of trust and creating secure and healthy attachments. If these early relationships are interrupted or dysfunctional, basic emotional needs may be met inconsistently or not at all. In situations like these, early emotions can range anywhere from confusion and sadness to deep-seated panic and fears of abandonment or rejection. Eventually, a child may desperately cling to caregivers for approval or learn to avoid them in self-preservation.
Without intervention, the attachment style, or blend, that develops during infancy and childhood tends to remain as we mature through puberty and into adulthood. For those clients with insecure styles, they may have been left with a legacy of unmet needs, unpleasant emotional triggers, and feelings of inadequacy. 4 basic attachment styles are identified in literature: secure, anxious preoccupied, dismissive avoidant, and fearful avoidant.
Most participants find that they have a blend of features from different styles. As clients identify their experiences and work through these styles, they may need to be reminded to be easy on themselves. This recognition work may bring up unpleasant, painful, and very raw emotions. However, early identification and recognition of these features can help us focus on overcoming the emotional legacy of past experiences that continues to affect their mental and metabolic health. Participants in BreakThrough virtual and in-person sessions often share that hearing other people's experiences, the similarities as well as the differences, can be reassuring and helpful.
Here we can review some of the features of the dismissive avoidant style of attachment. In the workbook, place a check mark next to the statements or descriptions that best reflect your experiences. These are some of the features of the fearful avoidant attachment style. You'll likely recognize that there are some similarities across the styles. Most of these similarities point to early needs that weren't met consistently.
Some of us will align with the dependent styles of attachment. It's natural then that when our needs aren't being met in relationships, that we may turn to other behaviors such as excessive volunteering, smoking and substance use, episodes of binge eating, gambling or gaming, shopping, the use of porn, hookups, or infidelity. It's natural only because these behaviors provide temporary, mood-altering relief from how they're feeling at the time. For most of us, when we're feeling down, we're subconsciously motivated to do things that will make us feel better. However, any cycle of emotional dysfunction that leads to an increase in the frequency of problematic mood-altering activities or doing nothing at all will likely result in internal conflict. Across all ages, cultures, and socioeconomic variables, internal conflict has been a significant factor in the development of depression and anxiety disorders from the dawn of time. Internal conflict starts with thoughts like,
I really shouldn't have done that. Or,
There you go again. You're never going to succeed.
self-critical thoughts increase our fear-based feelings such as anger, sadness, hopelessness, or even despair. Our challenge is to become willing to identify our emotional triggers and explore cycles or patterns of self-defeating behaviors. Family of origin is a term that describes the early family environment and the culture that we grew up in. For various reasons, including the questionable mental health of our clients' parents, some participants may have endured rather than enjoyed their childhood and adolescence. Unfortunately, the resulting fears, low self-esteem, harsh inner critic, and mood disturbances, such as pervasive depression, anger, or anxiety, often shadow our clients when they leave home. Typically, it's not until things begin to go wrong or they experience disappointment that there's sufficient reason and motivation to question long-held thoughts, feelings, and choices. Throughout the coursework, we explored these early family experiences to help us understand how we internalize these interactions, how these may have influenced the development of our inner voice, and how we may have been trained to see ourselves. As sessions unfold, we dive deep to explore and recover from internalized shame. Internalized toxic shame can occur when early experiences of co-regulation go wrong. This doesn't necessarily mean that a caregiver was abusive. They might have been emotionally illiterate, suffering with mental health challenges, or lack the skills to regulate their own emotions. We know that relationship dynamics and conflict can be a significant trigger for mental health conditions, as well as emotional eating behaviors. An entire session discusses relationships and the associations with emotional processing, eating behaviors, and metabolic health. However, relevant factors such as self-perception, fears of rejection, judgment, disapproval, abandonment, as well as resentments will surface early in discussions and coursework. These feelings are intense and among the most debilitating sources of psychic pain. Initially, those of us who experience betrayal or rejection may be apprehensive about sharing or joining in on discussions. We may experience outright fear of being judged, found wanting or somehow less than, coupled with the belief that,
if you really knew me, you wouldn't like me.
these negative feelings are the byproduct of toxic or conditional love and may be further fostered by racism, prejudice, stigma, and marginalization. Unfortunately, feelings of inferiority may be further reinforced by neglect, emotional, physical, and sexual abuse. We'll remind you to be gentle with yourself and remind you that you're not alone in this process of discovery and recovery. To avoid patterns of conflict that lead to emotional and behavioral relapse, we explore practical techniques for understanding communication and relationship dynamics through the lens of transactional analysis, as well as suggestions and techniques for nonviolent communication.
Cognitive behavioral therapy, CBT, is often the intervention of choice for effective behavioral change and weight loss programs. CBT is based on the principle that dysfunctional thinking gives rise to the development and maintenance of psychological distress. The emphasis of CBT is to help people examine self-defeating thoughts and behaviors and recognize how these thoughts may be affecting their day-to-day functioning. CBT isn't overly concerned with the psyche and past, it's more focused with the present. There are numerous versions of this approach, however. Most variations encourage setting realistic goals and actively practicing skills designed to promote positive behavioral change. For some clients, we may recommend dialectical behavioral therapy, DBT, or mindful-based stress reduction, MBSR courses to further develop specific techniques that help with positive emotional regulation and distress tolerance.
In Session 4, we discuss compulsiveness and the science of addiction to help us understand how the brain develops response patterns and preferences for certain substances and activities, and what we can do to challenge learned behaviors. This information helps us understand how the brain develops preferences for certain substances that unconsciously prompts compulsive or unhealthy seeking behaviors.
In an era of social influences that glorify excess, it's difficult to appreciate the concept of enough. The concept of enough, however, is essential to our sense of well-being. Participants often express feelings that they are not enough, that they haven't accomplished enough, or that they'll never have enough regardless of what enough might be.
The good news is that we can learn how to recognize and recover from negative and self-defeating thoughts with techniques designed to restore positive cognitive control.
Rational emotive behavioral therapy is introduced as a straightforward approach to challenge damaging beliefs, old thoughts, and negative patterns of impulsive behaviors.
When we recognize our patterns and triggers for emotional or impulsive eating behaviors, then we can identify personal choice points. These choice points may be as simple as driving past our favorite espresso stand or bakery, or avoiding late-night snacking by going to bed. As the course progresses, we introduce specific mindfulness skills and techniques. To avoid debate, we encourage our clients to take the best and leave the rest.
The important takeaway from this introduction is that by the end of the first session, clients are already beginning the recognition stage and developing self-awareness. To help build insight, over 560 introspective questions are sequenced throughout the 170 topics in the course text and online platform. These questions are designed to help participants develop insight and choose the skills that will best support their mindset of recovery. One final note in this session is that when our team is leading breakthrough groups or working with individuals, we take a very inclusive approach. We teach from the inclusive we or our perspective, from lived experience, and this approach is reflected in all the course presentations and learning resources.